Good morning, everybody. Welcome to the third session of our Franklin Grand Isle County Health Service Area Learning Collaborative, 2022 Learning Collaborative. We have great representation from law enforcement, education, government, healthcare with us today. Just really thank everybody for coming and being part as we embark and continue this collective learning that we've been doing now for 4 months or 3 months. Thank you to all of the presenters. We've got some great presenters today who have dedicated a tremendous amount of time and resources to preparing for our presentation today and sharing their expertise and perspectives. What is a learning collective? I want to bring this up every time just so that everybody is grounded in what we're trying to do here. Essentially, learning collaboratives combine learning and social connectedness, provide peer-to-peer and expert-to-peer learning. Through learning communities, peer organizations come together to focus on a problem, explore the challenges, and co-create solutions. This past week, I had the opportunity to attend a collective impact training, and the closing speaker, Dr. Revlin Starsky-Wilson, who's the CEO of the Children's Defense Fund, really just gave us an impassioned plea about the need to create spaces together now more than ever for this collective gathering and a collective learning to re-energize ourselves and the work that we must commit to help build more connected communities. As we emerge from this pandemic and are feeling slow, lethargic, depressed, whatever you might be having, we have to remember that coming together is critical, not only for our human need, but overcoming that feeling. And I can't think of a better way to do this. And unfortunately, this is virtual. Hopefully soon we will be back in person doing these in church halls and basements. But welcome everybody, and just remember why you're all here, and just extremely grateful for you taking the time to really connect and be together this morning. This is just a quick Wordle that we did after the first learning collaborative around in January afterwards, just really asking people what they were excited about in terms of a learning collaborative. And just, you know, that word collaboration just resonates. Also hope, progress, integration, and revitalization. I think all of those words on this screen just really exemplify why it is so important that we come together and do this work. Just our final slide, I just want to remind everybody, we had our February event for the 2022 Learning Collaborative. March was focused on death by overdose. Today, we're going to be talking about the care in healthcare, the links between clinical and community care. And I'm very excited, the May 20th presentation about building a trauma-informed community. We actually have a national speaker, Krista Goldstein-Cole, who serves as the Director of Research and Learning Initiatives for the ANSR Foundation, who also is an adjunct professor at the University of Montana. And her work has focused on creating and building trauma-informed communities, and the work that she's been able to do in Washington State. So excited to welcome her. More information and details about that learning collaborative will be forthcoming. I'm actually going to turn it over to our wonderful facilitator who has pulled all of this amazing work together for us over the last few months, and consistently keeps us on track. Jen Nauer, who will be sharing our agenda for the day today, for the time that we spend together.
Yeah, thanks, Denise. Good morning, everyone. So I've got 2 notes for you. I'll pull up the agenda, but I also wanted to let you know we're trying out something new on the technological side today, and that is using the video function as our technical stage or our virtual stage. Participants in the room, you might notice that you don't have the ability to turn on your microphone or your video quite yet. And so those of you who are presenting today, as you get closer to your presentation, you'll have that opportunity. And participants, when we do question and answer, you'll also be able to turn on your microphone. But for now, it's not a technical glitch. We're just trying something new to try to streamline what we're seeing and hopefully give you all a chance to sit back and relax if you're here to enjoy the presentations. Here's the agenda for today. You'll see a mix of presentations with question and answer throughout. We have a nice long time for a small group discussion at the end of the morning, so from 11 to noon. And you'll see those 2 10-minute breaks at 9:30 and at 10:45 to give you a chance to be in your body again and just get some balance from the Zoom screen. Denise, is there anything else I've forgotten on the logistical side of things?
No, I don't. I mean, I don't think so. Obviously, this session's being recorded. The invitation is, generative and open, and we're grateful that you're here, understanding all the pressures that everybody's under, always. So if there is a need for you to get up and do what you need to do, please don't hesitate. But we're excited that you're here and excited that you're participating. But again, if all of this is posted, and I can put the link in the chat later on, but everything will be posted. All the recordings from all of the sessions are posted in the Northwestern Medical Center website. We've created a Learning Collaborative page there to host all the materials.
Great. So if you have technical questions, crew, please put them in the chat and I will respond as soon as possible. And otherwise, Denise will step back so that you can begin the day with our community and clinical care linkages intro. Are you ready for that?
I am ready as I will ever be this morning, I feel like. All right, so now do you want me to reshare my screen, Jen?
Yes, if you have slides you'd like to share. I don't know that I have them pulled up yet.
Yep, hang on 1 second. I just have to get there. Just want to make sure I'm sharing the right screen. Is that the right one? Nope, I need to share 2.
Happy Friday, everybody.
I know, it's a complicated day today.
Yes, it is. It looks great.
Okay, all right, so I'm gonna move forward here. All right, so good morning, everybody, again. Chris Smith and I from the Howard Center, who sort of envisioned this with the rest of our wonderful committee of collaborators, really wanted to talk a little bit more about what we mean by the connection between community and clinical care. The first 2 sessions really focused on intervention, treatment of death to prevent death by overdose and death by suicide. And really one of the pieces that we wanted to bring forward to this group is really that the importance of community, not only in the process of treatment and recovery, but also in how prevention works to prevent things from going to the need of treatment in the first place. So welcome to the session. And why we thought it was so important to pivot and why this frame is imperative to move our work to solving complex social health and well-being problems in our community. So what do we mean about this connection? What are the intersections between prevention and treatment? And how do we as a community work to remove barriers and make it easier for our friends, family, and neighbors? Because that's really who we're talking about when we're talking about our clients and our patients, to access resources. And what resources or efforts are hiding in plain sight is what we're really going to be talking about today. So in my mind, and this is, the world of Denise, so you can take it or leave it, but really in my mind, I think that community care and clinical care are 2 sides of the same coin. On one side is prevention and the other is treatment. Not one is better than the other. They are not interchangeable, however, and they each have their own unique characteristics. Extremely important to the health and outcomes of our friends, neighbors, and family members. Interventions or treatment by nature is a reaction to a problem, right? Something's already gone wrong. Prevention by nature is nearly invisible and should be part of the fabric of any community. In communities where this is happening well, these 2 sides work together to create a safety net that is near fail-safe. In the learning collaboratives that we did earlier this year, we looked at how community partners, and I mean that in the largest sense of the word, including both clinical, organizational, and individual entities, may take action to reduce death by suicide and reduce death by overdose. These include, importantly, the intervention of talking about these issues in a way that reduces stigma and makes services more accessible and supports trauma-informed harm reduction principles in whichever corner of the service delivery practices we are in. Today, we'll be looking at the linkages between that clinical and community care. How do we support and understand that upstream work? And how do we support a robust community response and prevention? What are the ways in which healthcare supports the community and the community supports healthcare? How do we as collaborators and individuals create safer communities? I'm going to tell a couple of stories next. I think these are important stories because they really show how the environment really impacts outcomes, I guess I will say. So the first story is about the duck covered in oil. And I'm sure everybody has seen this picture, right? Or maybe not this specific image, but remember the oil spills and the birds that have been rescued. So if you think about this duck who's out in his environment, just swimming along, and then, the oil spill happens and he gets covered in oil. And then, we discovered that we could help the ducks, right? So we bring the ducks, if you want to think about this kind of as a clinical intervention, the duck is already hurt. We pick the duck up, and we take him inside, and we clean the duck with Dawn dishwashing soap. Oh, there's a lot of pictures of Dawn when I was putting this presentation together. And then you have this really happy, clean duck, right? And so the duck is clean and he goes back out into his environment, and lo and behold, there's another oil spill. And so what happens to the duck? Again, he's injured. And so really when we're talking about working upstream, we're talking about preventing the oil spill from ever happening so that the little duck does not get covered in oil in the first place. So the next story I'm going to tell, and this is and I want to give credit to Amy Brewer, who's on this call from the Franklin Grand Isle Tobacco Coalition, and Crystal Lampman from Caring Communities. We put together a presentation a few years ago, actually right before the pandemic, and it was based on data that we had collected of the point of sales data and the YRBS. And really, it was done to showcase the causal relationship. We didn't know that it existed when we first started the research. We hired an epidemiologist to look at the data, but it was done to showcase the causal relationship between the built environment and the impacts it has on youth tobacco and alcohol usage. We had an idea that there would be a causal relationship. So we used the YRBS data, and we data set and point of sale data from about 89 local retailers. The local research determined that placement of ad signage correlated to more alcohol and tobacco usage by youth. Increased tobacco product use in the last 30 days was associated with prevalent interior and exterior ads at retailers, and as well as increased alcohol use in the last 30 days was also associated with prevalent interior and exterior ads at retailers. So we have Tyler, and he walks to and from school every day, starting in kindergarten and at age 5 and continuing through his senior year. This is just multiple pictures from around our communities. So this is St. Albans, I think Swanton, but really it's the high density. What you can see kind of in the words is the high density of advertisement in store windows within walking distance of area high schools. Illuminated ads can be seen across the street from one of our local high schools, and there's high density of ads in store windows within walking distance of area high schools. And there is intentional marketing of tobacco products to youth, which is being a cause of young people smoking tobacco. So I just want to show you this slide, because if you think that Tyler only lives in New York City, you could be assured that Tyler actually lives right here in Franklin County. The next slide really is to explain, and this is actually, and I just want to point this out, this is only images that he's seen outside of buildings. This does not include YouTube, Facebook, all the other images that are from media that are coming at him. But by the age of 18, he'll have seen images of alcohol and tobacco, 46,800 images if you do the math, and there's 180 school days, and he walks to school every day or goes on the bus to school or sits across the school in a building looking at these ads every day. His exposure just from walking to and from school is intense, right? And this is happening locally right here. And so when we're talking about the environment, we're talking about this environment. And the next slide really kind of is a mindset that I learned about. It's an idea that I was exposed to about the internal and external conditions of health, if you will. And it really resonated with me and continues my analogy of the two sides of the same coin, right? Our community and our families, our neighborhoods, our outside influences are the external conditions that influence our overall conditions, our internal conditions. So ourselves, if you will, right? Our internal conditions. External conditions are obviously not the only things that impact us, but they have greater, oh, I went one slide early, hang on. They are not the only thing that impact us, but they do have greater influence. The external conditions are how a community is designed and what the conditions in that community that either nourish or deplete our internal conditions. So really, as we kind of go throughout the day, I've put some questions over here on the side, and I just want you to think about them. You know, how does our community's external condition nourish our internal conditions? How does our community's external conditions deplete our internal conditions? And what can we do to create the conditions in our community to support healthy outcomes for all to thrive? The next slide, I just think it's really important before we talk about what we're going to do about it. We have to really think about what I think is really human-centered, person-centered, community-centered design. That we really, and this is a word we use in healthcare a little bit, nothing about me without me. So as we work to think about the work and the work that lies ahead, we also have to consider how we do this work, who is involved in doing this work, and how do we include the voices of those who have not been included in our past efforts. How do we truly build health equity, and what systems are creating barriers to access either by design or by default? I like this nothing about me without me. One, it's simple, so I can remember it. And it reminds me that we should never be talking about others without including them in the conversation. It's truly a person-centered mindset that we need in order to move any of this work forward and have it be successful. There is tremendous wisdom in communities, and that wisdom needs to be harnessed. And the systems, environments, infrastructure, and programs we design need to be designed with the people who are impacted and who are most impacted by the decisions being made. Which brings us to my next slide, and we're going to be talking about this a little bit later on with Laurel Ruggles from the Vermont Prevention Institute and Aaron Creeley. This slide is totally stolen from the Vermont Department of Health as they embark on a CDC health equity project, which we are involved in our accountable community for health in our health service area. But really, I just want to talk about this slide because to me, this was, it just demonstrates the work and where we've been focusing and where we actually need to move to. So in my world, I've been really working in the living conditions probably for the past 20 years. I've done a lot of work on in communities, on community engagement, physical environment. We did a lot of work in social environment with RISE. So that's really where I've been focusing a lot of my work. You know, and what we really need to start looking at, it actually goes a little bit more upstream than that. And our interventions, and even before looking at the living conditions in a community, we actually need to address the social and institutional inequities that exist in our community, either by design or default. These inequities exist. And the work has to start there in order to support healthy community designs and create the external conditions. and I'm going to say this, where everyone can thrive, right? Because what happens is if we design these systems, or if we ignore this and only look at the living conditions here without addressing this, we will never get to a point where everybody is fully participating in a healthy community. I'm really excited to be here today. I'm really excited not only to hear from my colleagues, but also community partners. And I'm excited that we just have so many incredible community members and partners at the table. I really want to make sure that we are engaged with prevention. We think about prevention as a beginning, as part of the healthcare system. How we integrate this work into our continued shared learning and community design. I'm now going to turn it over to Chris Smith from the Howard Center, who will tell us a little bit more about how we create systems in our communities to be less shaming and less stigmatizing, to recognize that actually it's expected that most people will need various levels of support and different types of support throughout their lifespan. So I'm going to turn it over to Chris because it goes back to that duck story. If you keep healing somebody and then sending them back out into the environment without the right supports, then the oil will just keep making him dirty, and he'll just keep showing back up that emergency room and need the Dawn soap. Chris, I'm going to turn it over to you, and I'm going to stop sharing.
Chris, are you able to turn on your video, or do you need some help?
Nope, I should be here. Presentation mode, sorry about that. All right. Good morning, everybody. Thanks again for being here. We're really happy to have you all. I'm going to continue the thread that Denise put forth about the cyclical nature of prevention and clinical care. And we really want to spend some time this morning talking about these community connections and how people will need various levels, as Denise said, of treatment and prevention work throughout the lifespan. A couple of us were lucky enough to see Johan Hari a couple of weeks ago in person at the Vermont Recovery Foundation's annual conference. And he's got a famous, now almost infamous statement that has been almost shared and reshared in many different settings, that the opposite of addiction is not sobriety, it's human connection. And I think for today, that's an idea I'm going to try to hold and generalize to situations that extend beyond specific scenarios for substance use treatment. I think what we are going to begin to look at is, how does this idea connect to other health issues that people in our community are dealing with, whether that's a chronic illness, a mental health or substance use disorder. I think we've got pockets of individuals who really lack human connection and whose problems are exacerbated by isolation, and particularly have been challenged over the last 2 years of further isolation as a result of the pandemic. We want to consider overall, I think Denise's first question and premise, what do you do to build a safer community? One of the answers to that question that I'm going to spend a few minutes talking about is the establishment of supportive relationships. There's a lot of evidence out there that shows that the more connections that you have in your world, in your life, the better your health outcomes are. Scientific evidence shows that the involvement in social relationships have huge benefits for health. The most striking evidence comes from the prospective studies on mortality across industrial nations. These studies consistently show that individuals with the lowest level of involvement in social relationships are more likely to die than those with greater involvement. Reading that, to me, feels staggering because the connection that we can establish in our communities is often the lowest cost intervention that we can provide. A trip to the emergency department is expensive. And we're going to hear from organizations today that are focusing on solving healthcare problems and healthcare inequities from a very different perspective than that. And I'm excited for people to have some time to think about the ways in which we can, regardless of our role in the community, encourage better connection with these organizations to better understand the work they do and the ways that they enhance the work that is being done across Franklin and Grand Isle counties and Vermont on the whole. There's additional information and research that talk about the way specific relationships, whether that's a mentoring relationship for a child or the therapeutic bond between a counselor and their client, the ability of a recovery coach to help an individual working towards sobriety and recovery make progress on their goals. And we're going to ask everybody today to think about the various relationships that you encounter in your professional and perhaps personal work, and where they relate to this interaction between clinical care and prevention work that we're going to learn about today. In our last event, one of the speakers, Mike Selleck, who came to us from the National Coalition of Harm Reduction, he talked a lot about this idea that we sometimes need to work harder than our clients. And this interrupted, I think, this idea interrupts a long-held belief among service providers that if we're working harder than our client is not ready to make the change. And I walked away from our presentation in March really thinking about this idea that Mike put out there, that if people could solve problems for themselves, that they would. And that perhaps we as providers, as clinicians, as helping professionals need to consider how and why individuals may have barriers to consider as they are trying to solve their own problems. A couple of just statistics to think about. On average, median attempts it takes to achieve recovery from any substance is 5. Specific to opioids, the average is 9. So if you think about the number of times someone returns to a treatment setting from a community prevention setting, they have a lot of opportunity to either experience support, a welcoming environment, an opportunity to review previous work, pick up on relationships, and continue where they left off. They also have the opportunity to re-experience shame, trauma, and stigma associated with seeking help for rather marginalized and undertreated chronic conditions in our community. I want people to think a little bit about how we can make it easier for those that we work with to enter and re-enter and achieve treatment goals as needed. How do we create systems and communities to be less shaming and less stigmatizing? To recognize that, in fact, it's expected that most people will need various levels of support across their lifespan. I want people to think about the organizations that we're going to hear from today and the wide array of programming that they offer, and think about how it interacts with the work that you do and ways to enhance these connections. We want to think about access points. We want to think about how people pursue the next level of care, whether they're going up or whether they're coming down out of treatment. How do we make sure that people continue to have access to relationships that they find supportive and nurturing, regardless of what they're looking for? We're going to hear from individuals that host play groups. We're going to hear from individuals that support families. We're going to hear from organizations that offer a variety of support to families, adolescents, and individuals across the lifespan. And I'm really hoping that as we wrap up today, we've all got a couple of additional ideas on what we can do to support and facilitate these relationships. Thanks again to all the presenters and the individuals we're going to turn it over to from here. Really excited to hear across the board today from our speakers, and thanks very much for your participation.
Thanks, Chris. So there's 4 spotlight speakers that we'll be inviting to our virtual podium. And I'm wondering if you want to maybe introduce them now in person, and then we'll cue you. So it'll be Belinda and then Amy Johnson will be the first and second. Chris, do you want to talk a little bit about from where each person hails, or how do you want to hand off the baton?
Sure. I think if it's possible to queue up Denise to do a little intro, that would probably be terrific.
Yeah, sure. So Denise,
on my stop share.
we're having sort of a funny, awkward Friday dance with our virtual podium today. And I want to normalize that a little bit, because I do, the planning team, and probably all of you in the audience too, it's been a busy time, and we are in sort of the brain, what do you call it when things collide? But those thoughts are not lining up as smoothly as we hoped. Denise, let's do this. Can you please go ahead and introduce the 4 speakers that we'll hear from, and then I will bring them each up in queue. It'll be Belinda, Amy Johnson, Mary Pickner, and then Amy Brewer.
Yeah. I love all of them. So Belinda Bassett and Amy Johnson will be joining us from NCSS today to talk more about the programs and ideas that they have and what they're excited about with prevention. We have Mary Pickner, who's joining us from the Vermont Department of Health. And if you don't know Mary, she's been working in prevention for a long time and has a breadth of knowledge, not only about that work, but about our communities. And then Amy Brewer, who is our Franklin Grand Isle Tobacco Coalition organizer, is a good friend as well as an amazing prevention expert. She is the one I get most of my ideas and thoughts about prevention. So sometimes we share a brain, especially on days like today. So I think if you can bring them up, Jen. There's Belinda.
Good morning.
Morning.
Good morning.
And I think Belinda and Amy are going to speak first. Is that accurate?
Yep, that's right.
Okay.
Right, Belinda, you're good to go.
Okay, thank you. So I am Belinda Bassett. I'm the Clinical Services Program Manager here in the Children's Division at NCSS. And so we were offered a couple of questions to discuss today. So I will go ahead and answer some of those. What I wanted to just say, though, was the introduction from Denise and Chris was just really thought-provoking. And I do feel like there's so much more to be said than maybe what I've prepared today. So, and I actually have to jump off to join another training. So I won't be part of the small group discussions, but I'm definitely looking forward to the notes and seeing what comes out of today. I think there's a lot of generative ideas and work that we can all be doing together. So I really appreciate that. And I appreciate the time to come and chat today. So first of all, I was thinking about when you were queuing up, thinking about prevention and intervention, I feel like the role that I serve here at the agency is a little bit more directly involved in intervention. So the programs that I supervise are children 6 to 18, and the services are really delivered in the home, in the community, in the schools, and here at the office. We do provide individual work for children to work on that skill acquisition. We provide the home and community-based intervention, and then the family systems work is really to target some of what Denise was recognizing earlier about changing the environment around the kids that we're serving, so that when new skills are acquired, going back into the same environment doesn't really support that unless the environment itself has changed and built skills and supports as well. So we do a lot of work with family systems. And then we have, most recently, we've really struggled to provide groups to kids in the past, but because of the virtual platform, COVID kind of gave us a bit of an opportunity there to provide more group intervention for children and families. And we've seen a huge increase in our capacity to serve kids and families directly, individually and in groups because of the virtual platform. So that's been really exciting because that's something we really feel like we could create a much deeper reach. And so that's been great. I do feel like without anything specific to Mark, there are a lot of collaborative relationships that we spend our time and energy supporting children and families around, our relationships with our education partners, our primary care physicians, our DCF partners, the law enforcement around us. We spend a lot of time really creating, providing psychoeducation training and support so that folks know when they're supporting children and families that there is a certain skill set that we'd like to call upon, and how do we think creatively when people are in a self-defined crisis. So that's a lot of the work that I do. So the second question was really about noticing the links between community and clinical care. Some of my noticings are a little negative, so I want to just honor that. I think to people's points earlier, resources are strained right now. People are trying to come out of the COVID struggle. I think people are, I'm noticing a lot of vacancies across our system. So the actual people to do the work we're really missing, and that can be really hard to do. The acuity in the kids that we're serving is pretty high. Depression and anxiety is fairly noticeable in all of the clients that we're serving right now to some extent. And with kids, as we know, that can increase behavior. So we're looking at high level behaviors, struggles within the family system to tolerate those behaviors. And again, the energy from the family in order to make the significant changes needed in order to be sustained stabilization. So, and I think all of our systems are feeling that. I think, from a mental health lens, we're feeling it. From an education, our partners are definitely sharing that. Primary care physicians are calling pretty consistently, asking for support and just really trying to brainstorm what we can do differently for kids. And so on a positive note, I think even though the resources are limited and people are really struggling to fill the vacancies that exist in our system, I think a lot of creative thinking is happening, a lot of collaboration. We have some really great examples of education systems creating programs within their districts that meet the needs of the kids that they're serving because their wait lists are so high in other programs. So that's been nice to hear. I know that we had an interesting meeting earlier in the week trying to come up with some ideas for a specific child with DCF that it just was really creative. And I really appreciated that people came to the table trying to think creatively. And in that vein, I am really impressed with, even though the stress is high, the strain is high, the vacancies are high, I really feel like people are not pointing at each other. I think we're really trying to just honor that everybody's doing the best that they can in the clinical care. And so I'm really thankful for that, because I think with this stress, it can really create space for people to worry and make some assumptions about what other people are doing. And I don't see a lot of that, which I really appreciate. And another thing that I noticed, and I said this at a LIT meeting last week, is that in our system, I've been here at NCSS for about 21 years. Actually, it has been 21 years last week. And I've never seen all systems struggle at this level before. So before, if there were vacancies in like our education system or in our DCF system, mental health was able to kind of provide additional supports to overcome and supplement that, or vice versa. If we were low, education and DCF and primary care could jump in. I definitely feel like that that has shifted. It seems like, even though we're being super collaborative, people are really having a hard time being able to offer more and to create more space to support each other. So I just really noticed that a little bit different than past years. And then I just wanted to highlight that for kids, the prevention that Amy will speak to is super important. And I wanted to note that we have heard from folks that mental health intervention is outpatient therapy, those kind of like stringent required programs and services. And I wanted to just highlight that 93% of our children's services programs are delivered to kids in the community, in their homes, and in the schools. So very, very high different percentage there, which I really appreciate. So I've just been told I'm out of time, but I just wanted to reiterate that I really appreciate the time today. And I do feel like one of the pieces that I want to highlight is that the social determinants of health work that we're doing in the children's division is something I'd like to spend a little bit more time talking about with Learning Collaborative folks. So thank you.
Belinda, thank you so much. And yes, the time is tight. So for a bit of context, your spotlight presenters have been given a couple of question prompts to answer, and there's so much more they could say. But thanks for condensing that and giving us the high points. Amy Johnson, are you available to come up to our virtual stage? You'll need to turn on your video. There you go.
I'm available.
Thanks.
Hi, everyone. I'm Amy Johnson, and I am the program manager of the Parent-Child Center of Northwestern Counseling and Support Services. So I want to thank Belinda for a great lead-in and for following the rules, because I probably won't, but I think Denise and Jennifer probably assumed I wouldn't. So I just want to talk about what's really exciting in our community is that we have a parent-child center embedded in our designated mental health agency. And so I just want to level set for folks who might not know what is a parent-child center and why does it matter. In Vermont, there are 15 parent-child centers across the state of Vermont. We are written into state statute as the primary prevention hub for the state of Vermont. And so what that means is that we're really focused on that multi-generational work, pushing upstream. All 15 of us are unique unto our regions. Many are freestanding, but like I said, ours is unique in that we're embedded in our mental health agency, which is really nice for that continuum of care. We do share 8 core services, and I know that Chris had mentioned playgroups, so that's one of our core services. Among several others. I did have a PowerPoint, but I thought it would be easier just to talk without having to flip through slides. So home visiting, community development, which means that in addition to providing services in the region, we're also working in tandem with partners to ensure that we're creating a better system for families and young children and pregnant folks. Parent education, parent support, information and referral. So if we don't do it, we'll be able to plug families into someone who does. Early childhood services. So most people, when they hear parent-child center, they think that we're a child care center, and we don't actually have a child care center, but we do support that system. We link families with child care, and we also help with the financial end of that as well. Concrete support. So this is a really big one. So if your ears have been off, just like turn them on, because if you have families who need something, it's diapers, it's wipes, it's formula, high chairs, strollers, grocery cards, gas cards, you name it, help paying for utilities, auto repairs, send them to us. We can help with that. We have a lot of creative and flexible funding that we've been able to use to support families. Because we are written into state statute, we also have a line in the governor's budget, which means that we have ongoing funding, and part of that funding does provide for concrete supports for families to meet basic needs. So that's kind of the long and short of parent-child centers. And one of the things that's happening statewide is directly connected to parent-child centers that I'm really excited about in terms of prevention. is the DULCE efforts. If you're not familiar, DULCE stands for Developmental Understanding and Legal Collaboration for Everyone. This is a national evidence-based model that's connected to the Center for the Study of Social Policy. And what this program is, the Parent-Child Center has a staff that is embedded in the pediatric practice. And so right now in the state of Vermont, we have 5 pediatric practices who partner with parent-child centers to embed that person who is part of the care team there at that pediatric office. In addition, there's a mental health lead who's part of the NCSS team. There's a legal advocate from Vermont Legal Aid, a physician champion from the practice, and then an early childhood lead, which is usually the Parent-Child Center director, and then a project lead. And so what this looks like on the ground, we have the family specialist who's a Parent-Child Center staff. They are on site at the pediatric practice, and they meet. It's a universal model. They meet with every single family at every well child visit from birth until 6 months. And they are in that office during those visits in tandem with the physician and with the nurses. So they collaborate, they work together. I will name the 5 practices in 1 second leading up to it. It's very exciting. So they're in every well child visit up to 6 months. And the idea is that we work with families, we discuss social determinants of health. There's various screenings. There's an UNCOPE screening for substance use. There's perinatal depression and anxiety screening, social determinants of health screening, and there's intimate partner violence screening. And effectively what we're trying to do is set families up to be healthy and well. So what do you need right now? You just had a baby. We've got the development piece and the health piece, but there's all these other things that families need to have that solid foundation. And so the idea is by the time they hit that 6-month visit, that they're well supported, they're well wrapped, they've been funneled in. So it's really that access point that Chris was talking about. So currently we in Franklin Grand Isle, our practice that we partner with is actually in Milton. Dr. Kristen Connolly, who used to be up here, who is now in Milton, but has many Franklin and Grand Isle families that she serves. So that's where we have our practice, but there are practices in Springfield, there are practices in Lamoille County, and the Timberlane in South Burlington. And so we're really excited because now we're working with the Vermont Department of Health on a HRSA, federal HRSA grant to add additional sites, and looking to embed ourselves into the OB practices as well. So if we come knocking on your door and say, hey, do you want to do this? Say yes, because it's awesome. And it's that upstream creative, get families connected and plugged in, and that healthy start that we're looking for. So when you see me calling or emailing, just say yes to whatever I ask.
Oh, Amy. So here's a signal that I just wanted to underscore is that you've given an example of that downstream to upstream. There's services all along the way. And your example is within a certain organization. I think as this conversation plays out over the course of this morning, you're looking at organizations that are all along that continuum and a community that's showing up all along that continuum so that people are supported as they go in and out of needing services at whatever level over the course of a lifetime.
Absolutely.
It's stunning. So in the interest of time, because we do have 2 more presenters, I wondered if you wanted to give any lightning quick answers to things you're excited about or longing for where it comes to community clinical linkages.
I mean, I think we want to see this grow. I wanted to name this specifically because we're seeing amazing results. If people are interested and want to see our data, we meet monthly we meet weekly to talk about every family that we see and discuss as a care team. And we also meet monthly with the national team in Vermont Child Health Improvement Program to do our CQI, Continuous Quality Improvement work. And so we have really amazing outcomes. 95% of families who screen positive are directly connected to the services. And they're not just services that the Parent-Child Center provides, it can be anybody in the community. So if you're interested in seeing our data, it's phenomenal. This really works. So I'm excited to see more folks learn about it and get excited about it and see it expand. And so that's not to just focus on one thing, because there's so many great things. First of all, Parent-Child Centers are awesome and Dulce is awesome. So yeah, that's what I have.
Amy Johnson, thank you so much. Mary Pickner from the Vermont Department of Health, you are up next. Are you available to come to our podium?
Yes. And
Welcome.
can I share my screen? Let's see if we can do that. All righty. Can you hear me?
We can hear you fine and we can see your screen. It's just we see all the backup too. It's not quite in presentation mode yet.
Is it thinking about it?
I don't know, maybe.
It
There
is
you go.
thinking. There we go. All right.
You did it.
So good. Yeah. So good morning, everyone. My name is Mary Pickner, and I am the substance use prevention consultant with alcohol and drug abuse programs at the state of Vermont. And I'm going to put my little timer on. I'm not sure what sound. Oh, it's going to make a motorcycle sound. Okay. So when I think about community-based prevention, we've had some really great speakers. And what I was thinking about was when we do primary prevention, as we try to follow the Vermont prevention model, but really it isn't working with any kind of individual. It really is about changing populations of people. And in thinking about that, we need to do that on a whole series of levels. And whether it's on the individual levels, when we think about changing, they say knowledge, attitudes, and beliefs, I think about culture, norms, and attitudes, and how we bring awareness to the way that we've always done things that we've never thought about, like that's just the way that it is, and start to think about, well, is that really what will be helpful to us and to our children and our health in the community long term, and then how our relationships are, as Chris pointed out, the opposite of addiction is connection. And when we think about doing prevention, connecting with other people is incredibly important. And we work with organizations, whether it's schools or businesses, institutions of all kinds. And the way that we tend to do that is not only doing that culture, norms, and attitudes, because institutions in particular, even our state institutions are very stuck in the way that it is, and they're difficult. It's difficult to make change in that, and particularly any kind of change, but particularly around prevention. One of the stalwarts, the central pieces of doing primary prevention is, I know Denise mentioned it, but we say nothing about us without us. And so working with the people that you want to have interventions and support them in making, whether it's better choices or better opportunities, better environment to live in, really is starting with them and using data and whether it's focus groups and lots of conversation about what folks want, and how we can get that done. And great examples of that has been Swanton on the Move, and then starting with Highgate. They've just started that process of Highgate reaching new heights, and that's an amazing thing. And the work that comes out of that is life-changing for generations. And that's where that community comes in. And then we do some work around policies and systems, and some of that things are, we have laws, and I think about alcohol that, and tobacco products, that we have like a minimum drinking age, and you can't purchase tobacco products or vaping products and alcohol until you're 21. We used to have a law that limited signage, so we could reduce that 48,000 images a little bit, and that sunsetted and it just never came back. But it's also how we look at the economics of our communities and the culture that influences, and then the media that we use ideally to help reduce the use of substances. My office manager is now going to stand on the computer. And so when I think about those kinds of things, and I think about the successes that we have, we really are looking at changing the environment for everybody. So we're not looking to, help one person with their high blood pressure. What we like to do is to be able to make the change so that everybody has the opportunity to, in future, reduce the incidence of chronic disease. I focus on substance use, but I know that the interventions that we use to reduce substance use in communities also reduce the incidence of every chronic disease and quite a few other public health issues like violence, domestic violence, sexual assault, gangs, and those kinds of things. Gives me 30 seconds. So that brings me to, the other thing that we talk about is unless all of us get better, none of us get better. All right. So when I think the links, we're all in to have wonderful, healthy individuals and communities and families. Clinical, I think, focuses more on individuals, whereas primary prevention, we don't really look at, in general, don't look at individuals. We really look at population level change and how do all of us get better. So I love to celebrate connections. And, we all focus on health and wellness, and, not only focusing on behavior issues, but physical ailments, and blending how we do our work through data and science is always, a wonderful opportunity. And, also recognizing that primary prevention, heals all people and reduces all chronic disease. Capitated payments helps, I think, push folks to wanting to do earlier intervention because they are always cheaper than the expensive ones that we find in the emergency department and beyond. And then broadening our understanding of behaviors and experiences that lead to chronic disease and the role that they play. And then, of course, strategic planning, because if we don't have a path, we never get to where we need to get to. And here's my hope list. Prevention takes a little longer to show results, 5-10 years, but the successes that we have are lifetime changes. Not only, our smoking and tobacco rate has gone down, our substance use is, probably taken a little bit blip, but I think about things like, seatbelt use, right? People, pretty much everybody uses seatbelts today, and that wasn't the case. And, designated driver is another thing that's been a great success. I would love to see it dedicating a percentage of kind of capitated payments to primary prevention, because these interventions address everything, and continue to share our knowledge, ideas, and keep changing our attitudes. I see you, Jen, and keep working to find common successes, continue to celebrate the great work. I don't think we celebrate enough, and I think we should do that more. And I want to thank everybody for the opportunity to be here, and, blessings and loving kindness to everyone. Thank you. Ta-da! And right here.
I know. Mary, I want to celebrate you. Thank you so much for that presentation. And I'm sorry for that feeling of rushing.
Fine.
I also love the motorcycle or chainsaw or whatever Rumble gave us the time frame. So we have one more spotlight presentation. We are going to bump the break a little bit later, but you'll still get one. So Amy Brewer, are you available to join us on the virtual stage? I'm going to turn on your video. There you are. Come on up.
Good morning. I was just trying to figure out if I could quickly share my presentation. So forgive me if I look one more time.
Is there anything I can do to help? I might have your presentation that I could pull up.
If you had that, I would be appreciative, because apparently I don't ever close a window and I cannot find it.
Okay, let me look for it. Does it say prevention offerings in Franklin, Grand Isle?
Sounds like that might be. I sent it last night. I apologize, everybody. while Jen is helping me with that, perhaps I can introduce myself. And Jen, if you can't find it, I most certainly can fix that problem that I'm having. Oh, there it is. Let's see.
See if I can get it bigger for you.
Well, actually, if you could, yeah, that'll work. Apparently, I sent you all my notes views. Oh, there we go.
How's that?
Welcome to the brain of Amy Brewer, which is not always a functioning one.
It's a collective brain and it takes a lot of contributions. Amy, no problem. Go ahead.
Good morning to everybody. My name is Amy Brewer. I coordinate the Franklin Grandisle Tobacco Prevention Coalition. Many of you know me, some of you do not. I'm also the health educator here at Northwestern Medical Center. And the Tobacco Prevention Coalition works broadly in our region to address tobacco control. And we do that in three giant ways. One, we do everything we can to connect people who do use a tobacco product or a nicotine product to the resources that will help them to quit for good, looking at the systems, helping everybody feel supported, and raise awareness. We do things that protect people from secondhand smoke, like smoke-free policies in parks and work sites, and that kind of thing. And then we do everything in our power to prevent young people from ever becoming addicted. And that's kind of where I want to start a little bit today. And I want to get very specific with you about kind of what prevention looks like in our community. And I focus a little bit more on youth today, although I don't always, but today that's where my brain went. So I want to share with you, so prevention amongst youth is not anything in particular. It's youth engagement and providing opportunity for youth leadership. And in our community, it might look like youth engaging in and feeling welcomed into Teen Institute, the Vermont Youth Project, which is busy in the MVU, Richford, and Enosburg areas. They might participate in the OVX VCAT initiative, which is youth empowerment related to tobacco control. They might be participating in after-school programs, whether they're leading them or a participant in. They might be engaged in their community in a different way. So all of those steps provide alternatives to substance use, but it also helps create strong individuals who choose to focus on being their full self rather than distracting that with substances. Another way that we can prevent substance misuse is by normalizing and supporting healthy behaviors. And so that might be making sure everybody has access to recreation programs, whether it's sports or arts, whether everybody has access to mentoring or the opportunity to volunteer and give back to their community. And then importantly, the people around them are modeling those healthy behaviors, right? So if we want young people to grow up making healthy choices, we all have to do that as well so that they see that's what's normal. On the flip side, it's really important to denormalize substance use and other unhealthy behaviors. And that's that modeling piece, but this is where a lot of the policies go, right? And Denise really talked about this perfectly for me in the beginning. So thank you, Denise. But what does our community look like? Are we bombarded with messages that normalize alcohol, tobacco, and cannabis use? Are they sitting in school looking out the window at tobacco and alcohol ads? Is there a new cannabis retail shop open up next to their high school or next to the rec fields, right? So how are we creating policies that really set the stage for what healthy life is? The last one on the slide is really giving individuals facts about substances without judgment. So it's not that just using substances are bad, but we want young people and everybody to really understand what it does to their bodies and about addiction and when addiction takes place, right? And not that you'll be a junkie, but what it does to relationships and future achievements and your body. And so making sure that, especially, we've done a really great job with this about smoking, right? Everybody agrees smoking kills. We've done less of a great job with it about alcohol, and I find more confusion about cannabis completely. So giving those facts is really very important as far as youth making those healthy decisions. And yes, would you please advance it? I see you're hanging on the arrow, which is perfect. So when we talk about how clinical care can prioritize healthy behaviors and help stop substance use, I broke it into 3 categories. They can advise and refer. So for clinicians, as soon as it is recognized that an individual is using, and my examples are all tobacco related, but so as soon as you recognize that somebody is using or at risk of using, make sure that quitting is a perfectly appropriate thing to do, that the individual can do it, and there's resources to help them, right? So 802 quits for adults, mylifemyquit.org for young people, right? As soon as you know, and every time when you're ready, I think you can do it. Here's the resources to help you, right? And then we also want to make sure that people have linkages to those health behaviors and resources. Have you thought about enrolling in a rec program or an art program? Or are you taking advantage of theater or music? How are you engaging in your community? I think you should. Here's how to do it, okay? Provide facts, and I just talked about this a little bit, but address substances early with judgment-free facts and addressing the root causes of why individuals use. And I think this is stress, this is misunderstandings, this is the environment around you. I know you're getting a lot of information about vaping right now, but let's talk about what we really know. And then if you want to go back one, thank you. And then the last thing that I think clinical care can do, which is slightly out of their realm of what might be considered normal, is clinical systems and clinicians can really lend their voices and expertise to help shape their communities and the resources that support health. Oftentimes, we're talking to select boards and we're talking to school boards and we're talking to decision makers in the community because we want access to recreation and we want people to be able to walk to school with free of alcohol, tobacco ads. And we're looking for those changes. And if clinicians kind of join in and say, this is why this is important, I think it adds weight to the work. And I think it meets the individual's needs. Okay, now you can go forward. Thank you. And so what's working well?
Sorry to interrupt, Amy.
Yeah.
One thing I just wanted to highlight there is your description of how in a community, there's so many different roles from select board to clinical to community-based to contribute to that safe community overall. So just carrying that theme forward. And in the interest of time, we do need to shorten up comments. And then, so I don't know, I'm probably going to rush you through this last bit, but your high level takeaways is what we're going to look for.
Great. Easy to rush through the next 2 slides, so I apologize for going long. What's working well? Collaborations that create opportunity and support. That's exactly what Jen and I were just talking about. They are individuals from different sectors of our world with different levels of decision-making and power, working together to shore up everything that is around an individual, right? That environment or that external conditions. And then there's collaborations that create change, right? So there's groups that come together and they're working on policy change and they're working on environment change. So, so there's a list of some of them there. That's not an exhaustive list, but Safe Routes to School and Vital Village and so many more. So if you want to go to the next slide, I can wrap it up. What the future could hold. I think there's a lot more systems changes that we can do that support clinician efforts in supporting prevention, right? Better EMR prompts, helping people directly refer to a cessation, right? It shouldn't be 3 screens away. It should be really quick. Say, here, you want my life, my quits, off you go. And better tracking so that we have better data. And I think those systems aren't strong enough yet. I think that payment should be made to clinicians for addressing prevention and cessation treatment. Really important payments because it's important work. I think there should be more confidence among all that supporting healthy behaviors and addressing the root causes of substance misuse are the effective interventions of prevention. Sometimes they feel nebulous, and that really can't, a sidewalk can't really be a prevention for obesity or depression, and it really can. And then lastly, communities that are designed with healthy behaviors in mind, opportunities that are connected, accessible, affordable, and desirable are really kind of the future of where we should go. So with that, I will stop.
Amy, thank you so much. I'm
My
gonna
pleasure.
add, yeah, no, I'm also, I apologize for the rushing as well. It does give that feeling of what I'm hoping is that all of these different things sink in. And I know you all need a break to help that integration happen. So Denise and Chris, what I'm asking for, if you would like to come up to our virtual stage, just a sentence or two that links all of these pieces together. You can think on it for a minute if you like. Then we'll go to a break. We had a Mentimeter poll that we're not going to use right now. So Denise and then Chris.
It's really interesting. Well, first, I'm really excited about the Dulce program. I hadn't realized that was, I knew that there was some initial work about a year ago, so I'm excited to hear an update from that, Amy. Amy, I think you're, and I think Jen commented on it as well, but the pull out of how clinicians can help with the prevention work, right? And help advocate. I mean, one of the data points that came out when we were doing focus groups on our beverage campaign that we did with Rise, and Emmy's on the call, she'll remember what we called it. My brain is not working this morning, but that campaign was really about how important physicians are, and when they talk to their patients listen to them, and that their advice, Sweet Enough campaign, thanks Emmy, the Sweet Enough campaign, when we did the focus groups, providers, medical doctors were where they actually get their health advice from. And so I think that is a really important point that we need to remember, and the critical role that clinicians play in the health behaviors of their patients. And I also think that there is a role for everybody to play in the advocacy work that needs to be done in communities to build healthier community designs. I think the thread of prevention and the different levels that are needed to encourage and change communities, right? And really it's at the policy level all the way down to the individual.
So in 2 sentences or less, Chris, and then we'll take a break.
I'll be brief. I really appreciated Amy Johnson's point around co-location and picking on a thread of how do we make things increasingly accessible, streamlined, co-located, and lower barriers for all of these services. And I just really appreciate the opportunity to continue thinking about that.
Thank you. Thank you to our spotlight presenters, and thank you to our participants for sitting through some technical glitches and then an awful lot of really precious content. So I hope you are able to take a break and integrate some of this content. You'll be coming back at 9:55, let's say. So that gives you a little less than 10 minutes. See you soon. Back on this link. I'm going to go ahead and put a little space saver in there, and I will be in touch with our next presenters via the chat.
People who operate and support programming work together. I think in some of the themes that Mary was really speaking to, prevention efforts that impact communities with the trickle down of impact for individuals over long-term health benefits. And I think we're going to hear a little bit about the perspective of that kind of work here in Vermont, and specifically about what we can expect in the future here in Franklin and Grand Isle counties, and to think about really our role as providers, clinicians, program managers, or consumers and constituents of this community. How do we play a role in this kind of work?
Mm-hmm. So Erin, I hope that we've given enough of a springboard for you to begin with, and you can add and fill in the gaps of anything Chris or I might have missed. So are you ready to come up to our virtual stage?
Yes, I am. Thank you so much.
Welcome.
Thank you. Hi, everyone. My name is Erin Creeley. I use she, her pronouns. I am the district director of the St. Albans Office of Local Health, which is part of Vermont Department of Health. I've been with the Vermont Department of Health in this role for 2 years. So for anyone who's been paying attention the last couple of years, there's been a pandemic in that time. So my work has been primarily focused in COVID. So I'm really incredibly thrilled that I get to join you today and talk about something that may be COVID adjacent because it touches everything now, but this is a real joy to talk about community connection and how we can collaborate. Previous to my work with VDH, I worked for One Care Vermont, which is an accountable care organization here in Vermont. We won't get into that model today, but I did want to share that as part of my work in One Care Vermont. I worked with partners in the state, both with the Blueprint and VDH and other parts of DEVA, Department of Vermont Health Access, to do some work and support around the accountable communities for health model in Vermont. So I'm going to give a brief presentation on the introduction of the accountable communities for health model. I'm going to share my screen. I will share that when I share my screen, it will be harder for me to watch the chat and see other people. So if Jen or anyone else wants to pop in, if there's something I'm missing, please do so.
Don't worry, I got you, Erin. I'll cover the chat.
Okay. Can everyone see my screen okay? Or Jen, can you see my screen?
Looks great.
Great, thank you. All right, so in the agenda for today, the 2 questions that we will be covering for this presentation are: what is an accountable community for health? And what is the value behind it? Additionally, what components does it pay attention to regarding how to strengthen the linkages between community and clinical care? And I think our speakers from this morning did already an incredible job of highlighting the importance of connecting community prevention work and clinical care. This model, as I demonstrate or explain it today, hopefully will be able to show how the accountable community for health can actually strengthen those connections. So what is an accountable community for health? It's both a what and I think a who as well. It is a model for collaboration that engages all levers of population health: social circumstances, economic conditions, environment, behavior, and more. It is also a cross-sector community membership that has representation from healthcare and social services, other service providers as well. Also representation from the community, individuals that may speak from a lived experience that is separate from being part of an organization. And all of those people are coming together with the responsibility of impacting it for the positive, the health and well-being of an entire population in a geographic area. This model was first identified starting around 2015 by the Prevention Institute, which is a national nonprofit focused on a mission to bring prevention and health equity to policies and actions at the federal, state, and local level. They, through studying initiatives and collaboratives that were already in existence, they were able to identify 9 core elements that they said defined an accountable community for health. Those 9 core elements are here on the screen. The smaller boxes next to those numbers are my addition, but these 9 core elements are what the Prevention Institute saw across all of these high-functioning community groups. The first thing that they all had was a shared mission. And this was a mission that was getting them all pulling together in the same direction, whether they were the hospital or the local shelter, they were all working towards the same mission. That might be the why of that group. Then additionally, who was there? It was a multi-sectoral partnership, which we talked about just a second ago. There's also an integrator organization, borrowing from the collective impact model, which some of you may be familiar with, that might also be called a backbone. That's an organization or group of organizations that help provide some administrative, organizational support to both the overall ACH and any of the working groups in the community to help further the mission. And then there's the how, and this is really where the ACH model has a lot of strength. We can get together and talk about the issues, but how do we pull together and what mechanisms do we use to make sure that we are effective in our work? So that is looking at shared governance, shared data and indicators, strategy and implementation, community member engagement, communications, and sustainable financing. I won't go into details on all of those. I will encourage folks to take a look at the Prevention Institute's website or checking out the Vermont Blueprint for Health's page on Accountable Communities for Health for more information on all of those details. But you can see those are the things that any organization or volunteer organization may be thinking about. And so it's taking the structures that help forward individual organizations and bringing it to the group to help provide that structure. So again, it takes those existing, it also takes the existing community collaboration that is there, and by using these 9 core elements, helps strengthen that to be focused towards the mission. So in an ACH, there are some areas of focus. This is from the Prevention Institute. So very broadly, an ACH is, again, looking at the health and well-being of a population in a defined geographic area. You'll see that come up a lot as we're talking through these slides. Additionally, there is an integration of high-quality medical care, mental health, and behavioral health services, social services for those in need. So that might be considered the care piece or the intervention that's happening in the community. Additionally, this work supports community-wide prevention efforts, and that's where we're trying to move upstream to address the issues that are impacting the health and well-being of that geographic community where it's happening in the first place. It's a way of reducing disparities in the way that health and wellness is distributed within a community. And again, as Amy and Mary brought up earlier in the morning's presentations, the alignment of where prevention and care or intervention happen is key. Providers in the care community have a great opportunity to impact the prevention strategies in the community, as well as prevention can speak to the care community and really direct how care is given in a way that is also addressing the prevention pieces as well. There's 2 images on this slide. I think that we've been talking since this morning around the social determinants of health. I wanted to put that on there as a demonstration of some of the prevention pieces and community pieces that an ACH is going to be looking at, because in the top image, and it may be small for folks to see, but that image shows that small 20% wedge up in the upper left-hand corner, that's clinical care. And that is one of the recognized percentages of how much clinical care actually impacts the health and well-being of an individual and in the community. Health behaviors, social and economic factors, and physical environment have a much bigger impact. So bringing those 2 together, so the care piece and the prevention piece, is key to aligning these efforts towards the shared mission of the ACH. This is a much more complex picture. I won't get into the specific details, but what it is meant to show, and this comes from Community Commons, is the upstream and downstream arenas or areas, rather, that we all live and work in. Oftentimes when we think about upstream impacts, we're thinking about the social inequities piece, we're thinking about living conditions and the ways that people interact with their environment as contributing to risk behaviors, disease and injury, and mortality. But what an ACH does is recognize as well that there are institutional inequities, and there's an opportunity to bring the community together to address the institutions themselves and the practices that are happening at an institutional level that contribute to downstream impacts. So we as speaking someone who is part of an organization, people who are in organizations, we have just in our structure an impact, and in an ACH we can work together collectively to address those issues and have real impact on the downstream. this is just a very quick, very speedy view of the evolution of the Accountable Community for Health model in Vermont and its movement towards inclusion and trust. In Vermont, there were two groups that were supported both through the Accountable Community, or excuse me, the ACO, OneCare, and the Blueprint for Health. So those were the UCC, or United Community Collaborative, and the RCPC, which is Regional Clinical Performance Council. Here in Franklin and Grand Isle County, we operate right now under a UCC and RCPC structure. So each of those groups are supposed to be bringing in hospital, primary care, as well as other service providers to talk about the health outcomes of our community. So both the UCC and RCPC were, mandated both from either the Blueprint or from OneCare as expectations for doing this quality care in our communities. Both OneCare and partners at the state recognize there's an opportunity to align those two groups because so many of the goals were shared already. So there was an encouragement of bringing those together in a collaborative committee with an expanded health system. The dotted line connecting to the ACH is a recognition that you can bring these groups together, but unless you have a model that helps strengthen those community connections, you're not going to further the work as well as you would like. So the ACH model is promoted within the state to help those UCC, RCPC community collaboratives come together and be effective for the long term and be sustainable in their efforts. The wedge at the bottom is showing that as more and more people come together to do this work, the need for trust between the groups increases. We speak often in our organizations different languages. Are they patients? Are they clients? Are they the public? Are they partners? How do we talk to each other? How are we speaking the same language? So as you increase the complexity of your group, the need for trust increases. And with having a clear structure with the Accountable Community for Health, that can help support the work to be trustworthy between partners. So very briefly, what is unique about the ACH model? I think we've covered that. So this slide is meant to just highlight, again, some of those unique qualities of the ACH. So again, it is engaging a broad set of partners, looking beyond just healthcare to include community, behavioral and social services, public health, and other organizations and sectors, focusing on the health of all residents in a geographic area rather than just a patient panel or a population, a subpopulation within a community. It also brings together the major healthcare and other service partners to be partners and not just individual actors within the system. These groups, when they align, are bringing together their multiple resources to be strategic to move the dial together on efforts that bring prevention and care together. And also there's the potential for braiding funding in order to sustain collaborative efforts. Right now, there's not a magic ACH pot of money. So how do we work together to make sure that the things that we value are funded going forward? So I'll pause and see if there are any questions.
Mm-hmm. It's a funny dance with questions because I'll need to turn your microphone on if you have one. So you've got two options. If you're in the audience and have a clarifying question for Erin, you can raise your virtual hand. You'll find that under, just jiggle your mouse over your Zoom screen. You'll find a reactions tab, or you can put it in the chat. And for context, this isn't the only time to be able to ask questions. We're just going to pause here for clarifications, and then there's a batch Q&A towards the end. Erin, thank you. What I think my move right now is to bring, Laurel will talk a little bit about specifically what's happened in St. Johnsbury. So this model in action, I believe. And then Denise will speak a bit, and then we'll all bring three of you up for questions. Does that help?
Yes, it does. Thank you. And
thank you so much, Erin. Laurel, are you ready to come to our virtual stage? Looks like you are.
I am. And hopefully my slides are showing.
They are. Looks great.
Good. Yay. So thank you, Erin, for that great overview. And thank you to all of you for having me here this morning. Denise mentioned that I am working with the Public Health Institute, and that is true. I'm working with them on some health equity work in the state. But I am here with you this morning because I am a member of NEK Prosper, which is the accountable community for health in the lower half of the Northeast Kingdom, Caledonia and Southern Essex. And so we've been around for almost 8 years now. And so with Erin's high level overview of what that structure is, I'm going to go into a little bit of a deeper dive for you this morning. I have done so many presentations on NEK Prosper over the years, and I almost always use this slide. It does not tell the whole story for sure, but it really holds true as far as you as a region, as communities coming together. If you really want to address those big problems, then you really will benefit from having that systemic approach, that structure to bring people together, whether it's organizations or people from your community, to come together, to work together. That having that structure and that foundation really does make a difference. So we do use the Accountable Community for Health model. Those 9 elements that Erin mentioned, I didn't use the slide here today, but I have slides that show each one of those 9 elements, that why, who, and how that we went through. We also use collective impact as a framework, which you'll hear a little bit more about that in the next few minutes. And then to measure our work, we use results-based accountability because it's really important to be able to see if you're making progress towards your goals, and that you're putting your efforts and your resources into the right things. Now, you'll see in the background this really fuzzy picture, and that is my feeble attempt to show that having these frameworks and that structure is important, but it's not all that you need. And that fuzzy background is kind of a graphic illustration of what I feel is also so important. I sometimes call it the kind of the secret sauce, because you can have that structure and bring people together, but if they work together well, it's not magic. And sometimes you also need a little bit of something else to help. And I was so happy when I heard about this concept of stewardship. And it's really the idea of that you wear 2 hats. We all have our roles and responsibilities, and whether we have patients or clients or whoever programs and services that we're doing, those things we have to get done at the end of the day. But if we can also think about how is our work related to everyone else's work, and how are we all, what we're doing, how is it related to what else we want to happen towards our goal of having healthier communities. Here's a little snapshot of who's involved in NEK Prosper, our Accountable Community for Health. We do, using the collective impact model, we do have a steering committee that's made up of 1 representative from all of the organizations that are listed on the left here. People from those organizations are all what I call active members, and you can see that on the right. It does include residents and community members. At the work group level, which I'll talk about in a minute, is where we have the best luck and have had the most success in bringing in people with lived and living experience. Here's just another snapshot of how NEK Prosper functions and operates. And this is really kind of a classic collective impact model, where you have a backbone organization, you have that steering committee that can set the strategic direction. And then we have what we call CANs, Collaborative Action Networks, but they're really working groups. In NEK Prosper, we have 5 outcome areas. We want our community to be well housed, well nourished, mentally healthy, physically healthy, and financially healthy. And so we have created work groups, CANs, we call them, in each one of those areas. Here's the CANs. As I said, it is a collective impact term. Our CANs operate under a very decentralized model where they have a fair amount of autonomy, but they also are held accountable for the work that they're doing. And also what I mean by the decentralized model is within each CAN, they come up with their own measures and gather their own data. They also, within themselves, they do their own work around communicating what they're doing, and also that community outreach and what that means as far as bringing in other people outside their standard members who are coming to meetings. Each CAN does their own. That's not a model that you have to have. You could have work groups that are focused on certain interventions or strategies within the community. And then you could have a work group that we're going to be the data work group for everybody, or we're going to be the communication, or we're going to be the community engagement work group. So you can do it many different ways. Because of all of you that are here today, I try to know my audience. I am going to do next few slides to focus on our mentally healthy CAN. In full disclosure, I am not on the mentally healthy CAN, and I've never been on it. I was on the physically healthy CAN for many years, and I continue to serve on the well-nourished CAN. So I'm going to tell you a little bit about what mentally healthy CAN does, but if you really want to get into more specifics, the best I'm going to be able to do for you this morning is I can give you some contact for people who are really there in the ground doing the work. But I'll still give you just kind of an idea of what they're doing. This was a screenshot from their page on the NEKprosper.org website, and you can go there at any time and get a better idea of what they're doing. What you'll find there is they have links to helpful resources like the COVID Support Vermont and Outright Vermont, and also a list of local counselors and therapists here. You'll find other tools and resources, reports and statistics, data, that type of thing. They also have a really nice calendar of events that are relevant to their CAN work. I went on the other day and they listed, they had the event of the NAMI support group, which just met this week. They also have AA meetings, and they had an online laughter yoga class that's sponsored by our designated mental health agency here in our region. You'll also see there that they have their own branded broad umbrella initiative called Positive Balance. And here's a description of it. Not all the CANs have done this. Some of them just do their work under NEKprosper, but the mentally healthy CAN has chosen this Positive Balance as a logo and this kind of overall branding for all of their work. And you see, it really also does a really good job of setting the tone for their work and gives you an idea of how they like to work together. I'm going to do a real quick, again, I haven't been part of this CAN, so I really only know what they're doing based on what I've heard them talk about, and also because I live in this community, so I can see what they're doing as well. Here's one of their strategies. They spent a lot of time in the last few years working with youth. It started with working with the You Matter program, where it was mostly middle school age kids. I think they had some high schools in there as well, who really took a deep dive into the latest youth behavioral risk survey, the YRBS. And I know this is an important topic to this group here, where teen suicide really stood out in our region. And so it became an important initiative that the youth identified and decided to work on. one of the best things that came out of that work was, for many, many years, probably decades, we had a youth advisory council here that was very, very active. And it had sort of over just the last few years had become less active. And, that happens sometimes with groups. Well, it's been re-energized because of the work with the Mentally Healthy Can. And as they like to say, the yak is back. And we're very happy that it is. So here's just a snapshot of what some of the things they have done around suicide prevention. They did offer Safe Talk training. They did some awareness through Hike for Hope. And then this slide features some work that they did within primary care. And I wanted to feature this because what you've been talking about today is that connection between, treatment, clinical world, and also prevention, and how it can all interact and come together. I just wanted to throw this up real quick, just because I mentioned that all of the cans use results-based accountability. This is just one of the measures that the Mentally Healthy Can is looking at. If you're familiar with RBA, you'll recognize some of the terminology, the story behind the curve, and the target values, and the trends. There's more of this on the website if you're interested in the data. I threw this up here because, and this is a slide that I use for the Well-Nourished Can, because I don't want you to think that the cans are doing all of the work in the community. That would be impossible, and it wouldn't make sense. So I did this to show how with the Well-Nourished, some of the new members coming into the Well-Nourished Can, as you can see sort of in the top and in the center, those are the organizations right now that are active in the Well-Nourished Can. But if you're really going to have a well-nourished community, you have to be thinking about all the other players out here. And there are other groups. We have the NEK Hunger Council, we have Food Coalition. You also have just other stakeholders and players that are out there. I don't know how you can't have a well-nourished community if you're not working with the grocery stores or the farmers, but they don't necessarily have to come to your monthly meetings. You can reach out to them and bring them in as needed. Right now, the Well-Nourished Can, we've been talking with a local businesswoman who runs 3 local grocery stores in our area, and she's very, very busy. So it's been kind of slow moving, but we're trying to work with them on one of our campaigns. So like the best frameworks, I feel like the best frameworks evolve. And Aaron talked to you about the kind of the basic 9 elements of the accountable community for health. And that framework is evolving as well. It does not mean you throw out the old, it's just you build on it. And this slide just shows how, you've got those 9 elements and a way of working together, but it just shows the complexity and the interaction between all of them. And also if you dig deeper in this framework for aligning the sectors, it also it allows you to realize you don't have to focus on everything at once. When you're forming your group, maybe it's more important to focus on governance. And at some point you can spend more time focusing on the data or how you're going to have sustainable financing. And this graphic just sort of illustrates that. It's not always equal amounts spent on each element. The other part of the structural and operational framework that's changing is the collective impact framework. And you might notice on the 5 original conditions that might look familiar to you from my slide that I had with all the ecosystem of partners for NEK Prosper. They're all still there again, but one thing that's been a criticism of collective impact is the couple of things I put on the right there, that really the community and that local voice and the voice of the community was really not featured prominently in the original framework. And then also just an understated role of how important system changes are and getting at those root causes. So this is a slide that I created for NEK Prosper just to show the old and the new. And the new model really has that health equity focus on it, where right now the mission of NEK Prosper is really to reduce poverty. Maybe saying something like making the NEK a better place to raise a family, or a better place to work, or a better place to age in place would just resonate more with more people. Around strategic learning rather than just shared measurement, data is very important, but there's really a renewed understanding in the importance of all of those stories and that anecdotal, how are people feeling about what you're working and what you're doing and how important that is. And then again, that system change, that's programs and services are important, but you also need to go, a little more upstream. As Denise was talking about, you don't want to just have a program that brings in more truckloads of dishwashing liquid. You want to figure out how you're going to stop that oil spill from happening in the first place. And then this is something we could talk about for days on how do you get that community voice into the discussion, and really thinking more about like who's at the table, who's at meetings, but who's making the decisions, and how do you make decisions on what you're going to spend your time on, what you're going to work on in the community. How do you bring those people with lived and living experience into those conversations? And then the backbone organization, which is always important. And this really isn't a change. If anything, it just really strengthens and amplifies that role. And then I'm going to end with, I've got my contact information here. And also, because I think they're probably going to share the slides, lots of resource links if you want to get more information. And that's it for my formal presentation.
Laurel, thank you. I'm thinking of one of the comments from Belinda's presentation this morning about systems facing a lot of demand right now. And one of the things your presentation highlights is this framework is an iterative, communal approach. And I put the emphasis on iterative because it doesn't happen in one meeting or even one learning collaborative. Or even a series of learning collaboratives. So a lot of complexity.
Yeah, that is so true. And it's often, I feel like my whole career has been 2 steps forward, 1 back, but that's still making forward progress. So it's okay.
Oh dear. So if there are questions, clarifying questions for Laurel, I'm going to encourage participants to put them in the chat or to jot them down for yourself. Because we will have a chance for a batch Q&A with Erin, Laurel, and Denise here in probably about 8 to 10 minutes. So Laurel, thank you. Denise, I'm going to invite you up to the virtual stage because I think what you're about to talk about is a status update of what the development of an ACH in St. Albans would be like.
Yep.
And then people might have more questions. So when you're ready.
Hi, Laurel, I appreciate that 1 step forward, 2 steps back analogy that you just gave, because I feel the same way some days. So I'm going to give an update, and I do not have any slides prepared for this, but just an update on where we're at with the development of the accountable community for health. Well, I'm not going to call it the development, the evolution of our accountable community for health in Franklin and Grand Isle counties. So this has been an ongoing project for many people in our community over the last 5 or 6 years. And most recently, we've identified that there's a gap in the structure that isn't allowing us to move forward as quickly as we'd like to. And so we've had what we've called for years now the Unified Community Collaborative and the Regional Clinical Performance Council. who have been functioning and working together to set strategic direction, identify resources that could possibly be invested in upstream collaboratives or upstream efforts. And as those groups have met, we've recognized that we are a small rural community. Many of the same people are attending many of the same meetings. And so we're really looking at how do we create a more efficient process in our region to be able to identify strategic priorities and build something similar to what they've done up in the Northeast Kingdom that really focuses the work in work groups that are able to move community priorities forward. And most recently, the UCC and the Regional Clinical Performance Council have agreed to begin merger conversations between the two groups, which we've been engaged in now since January. We've been meeting weekly, Friday mornings at 7:30 to talk about how the structure could change. At the same time, the Vermont Department of Health received a large CDC grant to recenter that work and work with Accountable Communities for Health on recentering the work on health equity and working more intentionally to include underserved and historically marginalized, intentionally marginalized populations in our communities. Really excited about the developments that are happening right there and now. We have a couple more meetings with the Unified Community Collaborative and the process now is that the ACH is going to be developing. We're actually building our framework, centering it in health equity and using or partnering more intentionally with the Abenaki Nation of Missisquoi as our backbone organization. So we're really excited about what's coming about. I'm going to actually probably invite Erin at one point to kind of do a little bit more explanation around this. She's been leading that work as the agency of Vermont Department of Health has the grant. But really, it's an opportunity, and this is what I want to tell all of you. This is an opportunity in our community to recenter the work, to redesign our Accountable Communities for Health, to create a framework where we can set strategic initiatives based on data, and hopefully move more of our population health initiatives forward to better serve our community. And as I said earlier, our community, our patients, our clients are actually our neighbors, our family, and our friends. Erin, what did I miss in that recap?
I don't think you missed much. I think the only thing I would add is, the funding that the state has to do this work comes from the CDC initially. There was obviously the pandemic was a big highlighting all of the cracks in the system that we already knew existed, but really showing that we were not ready for this pandemic to serve the folks that needed the service the most. So the CDC is funding work across the country and has given the state of Vermont a significant chunk of money to forward health equity initiatives across the state. And one of those chunks is specifically towards supporting the Accountable Community for Health or other community groups across the state to recenter their work in health equity, to make that a priority across Vermont. And so that funding includes a learning collaborative, which will allow for peers to share what they're learning through this process, as well as a 20-hour-a-week position that will help actually forward this work as the backbone or the integrator of this. And then also there will be some funds that each health service area, so Franklin and Grand Isle County, through this work will have access to approximately $150,000 that through the identification of needs in our community, we can give to community collaborators in this work so that they can help forward health equity as well. So it's very exciting work. It's pretty innovative, and that Laurel is deeply involved in that through her work with VTPHI. So if there's anything else I missed in this work, then she could absolutely speak to it as well. So maybe this is a good place for us to open questions for people, since the three of us are kind of engaged in this work right now as well.
Denise, did you have anything else you wanted to add before our Q&A?
I think the main thing is that we're going to invite, and I know we haven't planned a date yet, but in early June, we're intending to have a celebration or a kick. I'm calling it a celebration because of Mary now, a kickoff event for the accountable community for health, and really hope that many of you will be able to attend, invited, and be able to share in this work. So just as an FYI, it's as inclusive as we can make it at the beginning and throughout. So we want to make sure that everybody feels, welcome. The invitation is open, and I'm a firm believer in people who show up are allowed to lead. So and be part of it.
So you had a very specific, Denise, invitation to folks on this call around work groups. Is that still applicable, or is that different from your celebration kickoff?
Yeah, I mean, I think as we sort of develop the program, I think the kickoff is probably the most important thing. So thank you, Jen, for reminding me. But if people do want to be included in the work and in the ACH work and in that invitation, if you want to put your name and email, or actually are we going to do a Mentimeter, Jen? I can't remember what we had decided at the last meeting.
Let's do this. I have a poll that I'm going to launch.
Okay.
It'll show up on your Zoom screen for everyone in this meeting.
Yeah, so it was whether or not to keep you posted on the Accountable Community for Health work group. Thank you.
Yep. And so what this will produce, if you say, yes, please keep me posted, is it generates a report with the email that you signed up or registered for the Zoom meeting with. And that's the email that this group would be sending follow-up information to.
Got it. Thank you, Jen. Yep, for reminding me.
So
yeah, so just because you participated in the Learning Collaborative does not mean that we're going to email you about the Accountable Community for Health, unless you'd like to be invited.
Yeah.
It's a better way of putting it. Thank you.
Is there anything else you wanted to cover before opening for questions?
I don't think so. I think you both did a really, really phenomenal job explaining it. I am curious, and I wanted to ask this question after Erin spoke about how many people are aware or know about the Accountable Community for Health model or framework and or collective impact, and whether or not you've been involved or have participated in any of the past work that's been done. And I know that isn't a question, but if you do have any thoughts, you could add it to the chat. Or if this is the first time you've heard about the Accountable Community for Health, that would be another question.
So the floor is open now. If you're in the audience and you have a question, you can raise your virtual hand or you can put it in the chat. And your virtual hand is located on your Zoom toolbar. Jiggle your mouse, it will show up. You will see a reactions toolbar tab there. Or sometimes you can jiggle your mouse over your little thumbnail screen. And if you'd like to say something on air but can't find any of that, sending me a chat that says, I have something to say also works. So here's a question in the chat. Do you have a date and a time for the kickoff?
I think I can attempt this and Denise can jump in too, but our kickoff is probably going to be, I think we're aiming for early summer. We know summers are hard with vacations. We do want to get this work going, but there's some milestones within the Learning Collaborative that's part of the Community Health Equity Partnership Grant that we want to make sure that we hit first. And then we can work on the agenda for the kickoff. We're hoping sometime in June is our goal, and we'll share that with anyone who's interested.
So if people didn't get a message, let's say it's a month from now or several weeks from now, and they haven't seen something in their inbox, where would they look for a date and time if they wanted to attend?
They're welcome to email me. I don't know if we've got a platform yet where we would share the day and time. Denise, I think, would also be another good resource locally. So I'll put my email again in the chat. So folks can email me if they're just curious about where things are. Otherwise, look out for an email from Denise or I related to this. Thanks for everyone who said they were interested or curious.
The only other thing I would add is the community health needs assessment that we're in the midst of doing right now for the Franklin Grand Isle County. We've structured a little bit differently this year. We've worked with focus groups. We did some intentional outreach to community members that have not normally participated in that needs assessment. And we're in the process of pulling that data and information together right now. And the kickoff event is going to be an opportunity to walk through that data and build the data problem statement, as Aaron called it. We need to come up with a new name for that. But it's going to be an opportunity for people to reflect a little bit more deeply on the information that our community is telling us about the needs of the community.
The chat is relatively quiet, and so is the airspace, and I don't see virtual hands waving. So that might mean that there aren't questions. If there are, I think people know where to follow up and how to reach you. So I have an invitation to the three speakers. Go ahead, Denise.
I just want to recognize it's a little overwhelming, this information about the new structure and all of this. And it feels daunting, and I just want to recognize that it takes time to kind of think through all of this. And so if it's not in your comfort zone, totally get that, and really want to just recognize that it's even hard to maybe formulate questions. So if you need time to think about it and have questions after, you know where to reach me, and Erin's put her name in the contact. Laurel's very available as well. And so we're all here to kind of support this process going forward. But I want to just recognize that it does feel a little bit overwhelming.
Well, it's also
a lot of information.
Yeah, and it doesn't sound like it's the kind of event that is a train leaving the station never to come back. So it's not asking for a train ticket and then missing your chance. This is more an update that here's this structure that's starting to take shape, and hopefully it's durable and flexible, and will welcome those contributors and partners when you're ready. Right. So a final invitation to all three of you, and then we'll transition here. Is there one, here's what I'm thinking of. I'm starting from this morning when you talked about this idea of environment, clinical and community care all being part of the same community. Happens, those linkages are within organizations. I think this might have been Mary Pickner's slide, maybe, that she had all these different circles. So there's individual, community, policy. These themes have all been reinforced. After the break, people are going to get a chance to talk a little bit, and it's going to be talking not about all these policy frameworks, but what are you noticing, appreciating, and longing for in community connections? Is there any takeaway or link that you want to make before we take a break on that concept?
I would just say, you know, that everyone who showed up today, it just shows that they're interested in this. And that's a great place to start for sure.
Agreed. And there's so much great community connection already happening. But this isn't, we're not bringing a concept that's completely alien. We know how to collaborate. This is just one tool that can be useful in supporting collaboration.
Denise?
Tim Cummings put a thing in the chat that says, I want to say that most community members, ACH has been part of the alphabet soup. I've heard that out in the community as well from community partners that are not in healthcare. So, and that surrounds us. And this explanation has been very helpful. Yeah.
So funny, because back to Chris's comment about the importance of relationships, you don't have relationships with alphabet signals and symbols. You have relationships with people. and with organizations, and you get that sort of imprint of your experience. And then once it gets titled in a couple of words that are bundled together, it gets more abstract. But at the heart of all of this is the working relationships with each other and relationships with community. So I'm preparing to transition. Speakers, are you okay with that? Yep. Okay, good. So we've caught up with some time. So please take a nice generous break. Everyone come back at 11 where we can really settle into some small group discussions, informally paced, and I think really enjoyable. And I'll give you more detail about how that will work when we come back. So stretch, get something to drink, get a snack, and we'll see you at 11. Thanks all. Welcome. I'm chuckling a little bit about a comment from the whiteboard. We have, Chris, a direct answer. We have some facilitators who are helping with the breakout rooms for this next activity. Part of it has a virtual whiteboard that automatically assigns you names. They're not real names. It provides a little bit of anonymity, but also a bit of amusement depending on what you end up getting. So welcome back. This next hour is set aside, a little more than an hour, set aside to talk about some of the content from this morning and take it where you need to. So I'd like to share the discussion prompts and then talk a little bit about how these things are structured. You can see some of the material in the small groups. There's 4 main questions. Your facilitators will start up with a warm-up question, and those will be brief, mostly so you can share your name and see who's in the room. Small groups of, I think there'll be no more than 8 people per group. They're peer facilitated, meaning that you have brave volunteers in each room standing by to help you stay on track and stay on the discussion prompts to the best of their ability. The discussion prompts will be listed in the chat, so they will travel with you to the room. So each of you has some responsibility for seeing the content, but they're listed here on your screen as well. For the most part, these are conversational questions. That means we're not taking notes on your answers and there's no report out required. But do look at question number 3, which is a whiteboard. It updates in real time. So your facilitators will be taking some notes based on how you advise them on the links between community and clinical care that you're excited about and the kinds of improvements you're longing for. So we're using a whiteboard for the purpose that it updates in real time, so you get a chance to see what happens in the other small groups. It provides a summary of some of the content you're covering, and there is some semblance of anonymity to it, meaning that your Zoom registration is not attached to those responses. So candor is really appreciated and encouraged. Conversations in the small groups will not be recorded the way that this large group conversation is. Entries to the whiteboard, however, will be, so they'll be available to you in a summary note following this meeting. And it also gives the chance for those of you working on the Accountable Communities for Health project, you may want to share with other committee members some of the takeaways from this exercise. And so that gives you an at-a-glance reference point. One more note, bear with your facilitators with a whiteboard. This is a new platform for many of them, and trying new things for the first time, especially with a bunch of witnesses, is a really brave thing. So I do want to say, and facilitators, I'll get to you in a moment if I've left anything out, that just as if we were in the same room together and there was an easel sheet and markers on the board, if your facilitator needed help, they wouldn't hesitate to invite you to pick up a marker and add some content. So facilitators, if you need help with the virtual whiteboard, you're welcome to share the link with another volunteer in your small group, whoever's brave enough to try it with you. The only reason I'm not sharing it with all 50 of you in this meeting, or 29 at the moment, is because that would slow down the whiteboard quite a bit, I think. So facilitators, any questions before we transition here? One thing, I'm checking the settings here so all of you will be able to unmute yourselves and start your video once you get into your breakout rooms. And I do encourage you to turn on your camera during introductions if you're comfortable doing so you can all see who's in the room and connect with each other. So let's see, my last step is to put in the breakout in the chat here all the different questions so that you have them. They'll travel with you to each meeting and each room. And then I'll open up the breakout rooms if you're good to go. I think you are. If you have questions, you can reach me from the breakout room. Just let me know.
Thanks, Jen.
So for the recorded version of this event, what you're seeing now is the virtual whiteboard. Participants are still in small groups. They're facilitated by colleagues, and their joint answers to these questions about community and clinical care, their collective answers are getting posted on the whiteboard, which will update in real time. This will be a lot to take in on the video, so we'll have a summary note afterwards that has all of these entries static and big enough to view on the screen or on the paper. Welcome back, everybody. So I just want to remind you that at this point, we are recording this segment of the meeting. And so if your camera is on, your camera will also be, your view will be recorded for the link that gets put up on the Learning Collaborative website. So if you don't wish to be part of that recording, you can still participate, but just keep your camera off. Well, I have been watching the whiteboards hum along full of little additions, and I am wondering, there's some time now to share takeaways or what stands out from you from that experience. I don't know how many of you were able to see the shared screen while you were working on the whiteboard. Could I see a show of virtual hands to just see how many people were watching it develop in real time versus listening to it in conversation? So for some of you, this might be the first time that you're seeing the whiteboard. I'm not sure. Well, here's what I can do. I'm going to put a PDF in the chat because you might find it kind of hard to see this. It was taken about 4 minutes ago. So there are some stickies that have been moved around and updated. There's one of you who is really good about trying to straighten the stickies. So that PDF won't look exactly the same as what you're seeing on the screen. But if you can't see this and you'd like to see it more closely, you can go ahead and open up that document. Oh dear. So take a look at what's there. And for now, I think we can just let those stickies stay kind of still because I think people will need to be able to see them. And I will go ahead and zoom in a bit so that you can just see them a little bit more closely on the screen. If you do have any comments or observations to make, I welcome them. We have about 5 to 8 minutes to play with. You can also put them in the chat if you prefer.
Yeah, Jen, I think one thing that I would note with our team, we thought it was interesting how the left side, what we added on the left side was very minimal compared to the right side. So what we're longing for, we had a lot of great ideas and what we're excited about. And we ended up talking through that and realized that we're just excited about so much, but the people that were in that group are very action-oriented, solution-focused individuals that we were wanting to use the time to look at what can we do next. So then we took more time to go back to what are we excited about so we don't lose sight of all the fantastic growth and networking and collaboration that's happened. So, and admittedly, Amy Brewer and I were put in the same group, so that's why the cookies made it on the excited about list. But I think, you know, the embedded positions have been a big focus of being excited for those and also longing for more of that. Having various individuals from different organizations working under the same roof, it better supports the individuals we serve, but also strengthens our relationships with our partners so we can understand their process, their language, their, you know, and so that's been something that as that continues to happen is something we're very excited about. And also as we continue to want to grow, it's something that we'd love to see an increase on. And there was some fantastic networking just within the individuals in our team on the work that they're doing. So I loved this exercise and had a lot of fun with the whiteboard.
I know. The whiteboard is, well, it's busy. That's one. And I think, Melinda, to your point, when you do strategic planning, their brains go all over the place and every brain starts in a different spot. Sometimes it's the things you're excited about. Sometimes it's the practicalities that you're really working on. And so that makes sense. They're both valuable. Other takeaways or observations?
This is Chris. I think one of the things that came out of our group that I was a little bit struck by is the silos of information and people just not knowing what another segment of the treatment or prevention side of the fence offers. And that feeling like a really easy thing to address, right? It's not expensive to promote a flyer and other promotional materials so people no, okay, the Howard Center does this and NCSS does that, and the hospital has this, and the Restorative Justice Center can have that, right? Like that to me felt like a pretty actionable item, and a good thing to take away. And what I'm, it wasn't what I'm longing for. It was like what I'm capable of doing.
And to that end, Chris, something that came up in our group that I think is interesting to reflect on is it sounds like organizations have a variety of things that they refer to or educational materials they use, but sometimes there's not commonality between organizations, right? So if you have a single person accessing a variety of services, they may be being referred all over the place for similar services and or receiving different patient education, and there's no commonality or maybe limited commonality between some of the referrals that individuals are getting or the education that they're receiving. So there's a desire too to maybe kind of get on the same page as a community around what are the tools and resources that we want to support our folks with.
So that's an observation too that links back to the main theme from this morning, which is making those connections and linkages between community and clinical care. There are practicalities that make it tricky. And an observation that when you're working within an organization, like we heard from some examples today of it's a palette of different entry points within the organization, it makes it easier to speak that same language or share the same materials. And then when you're looking at community-wide, it's such an enriching, amazing, complex network. It's a different set of tools. And it probably gets updated or outdated as quickly as it gets updated. So not an impossible feat, but a different kind of discipline maybe. Other thoughts or observations, takeaways? I'm going to come back in and zero in on this orange sticky, because I know it's been a theme in the planning group. This recognition of being harder on the systems and kinder on the people, meaning that this evaluative assessing kind of work and systems change is to be unflinching in that look on the systems and kind to the people who are in them, within them, interacting with those systems. That people are coming and hailing from a lot of different situations right now. And systems improvements are only as strong as the relationships that are going into them, right? So I'm going to go ahead and move us into the wrap-up activities of this learning collaborative for today, unless there's anyone sitting on a comment that they haven't said yet. So Denise, I'm looking for your screen.
Yep. I was actually just going to say, one comment that I would like to share. I think this is this virtual whiteboard. I can imagine us being in person, and I saw a few people and I saw the cookies and food and immediately thought of Amy and Melinda. But the fact that this was really a generative activity, even though nobody, I think, that agreed to facilitate today had ever used it. So I just want to commend all of our volunteers, our brave and courageous volunteers who helped to facilitate the small group activity. Really kudos to you. And I think the questions really did generate some very interesting and great answers that I think are kind of a launching pad for some of the work that we need to do in this region and in our accountable community for help. So thank you, everybody.
Yeah, thank you for participants. It's always brave to participate in a day like this and give candid feedback and entries. And also thank you to the facilitators who are trying to figure out how to capture all that complexity in a sticky. It's not easy on paper or virtually. Chris, I'm also going to call you up to the podium here for closing comments. That's where we are in the day. And so I think, Denise, we'll start with you refocusing on the overall theme. Chris, you may have a comment to add, and then we'll move into the more logistical next steps.
Yeah, I mean, I think from an overall closing comment, I just want to say, this session was really about recognizing the links, and we focused a lot on that theme between prevention and community and then clinical care. And I think we were able to, one, not only recognize the linkages between the two and how people are interacting with the different in the different places and that continuum of care of a community, but also bring forward an example of an accountable community for health model framework that we're currently working on and that has had some success not only in the state of Vermont, but also nationally. And so I'm really excited about this work. And one of the things that came up in one of the small groups, I was kind of floating through the small groups, but really the excited that people are showing up, right? That people are coming and being present with all of the stuff that's dragging us down and has dragged us down. This feels like an exciting moment in that we're pivoting a little bit to what actually what needs to be taken care of in our communities that has sort of felt neglected over the last 2 years because of COVID. And just recognizing that this is, kind of a moment, I think, for gratitude.
I just want to add that, again, being appreciative of everybody's time and energy in these events, that it's also an opportunity for us to think about this collaboration and connection that has underscored the entire series of presentations and collaboratives this winter and spring. Whether we're looking at addressing death by suicide and how to better intervene as a community on individuals who live with chronic hopelessness, or people who are struggling day to day and moment to moment with substance use disorders that really put them at the brink of overdose, that we have underscored this idea that community and connection is the least expensive and also sometimes the most effective antidote to all of that. And by coming together with these organizations and thinking about what our role is in enhancing connection and collaboration, I think that we have some groundwork here that we can build on in the future. And I'm really looking forward to hearing our next speaker in May to wrap this up and maybe a big picture macro level. So thanks, everybody.
Denise, are you ready for me to put up? I have a Mentimeter poll now that we'll have a couple closing questions for this group to share on screen, but then also it has the meeting evaluation that follows. We won't share that as part of the meeting, but go ahead and put that in the chat now.
I think that's good. We can give people maybe a little bit of time back, as you fill out the Mentimeter.
So folks, in the chat box, you have a link there. If you click on it, it will open up another browser on your screen. I believe, Denise, correct me if I'm wrong, this same link will go out with any kind of summary note from today.
Yeah. Yep.
That first question does have a word cloud question on it, so I do want to pull that up if you're able to connect to it. In a word, it asks, what's one thing that stands out in safe, healthy communities? And you can submit up to 3 entries. While people are looking at that, Denise, are there other announcements that you want to pull up? Because it looks like the poll is a little quiet right now.
I'm filling it out. So
okay.
it's
Sorry.
okay.
Sorry. Go ahead and fill it out and then come back to us. It's fine. You have time.
We have to put in 3 answers before it actually populates the word cloud, I think. That's why, maybe.
Yeah, there's a lot of answers starting to come in now.
Okay. Takes a little bit. 3 is a lot to think of right now. I mean, I think that, just the hopefully you'll all stay engaged and be part of our accountable community for health work. The community health needs assessment data is going to be released soon at the beginning of June as part of that, and just really excited to work together as we move forward and hopefully away from the pandemic. So it does look like the word cloud is coming up. I don't know, Jen, was there something else that I needed to say at the end or to wrap up that I'm missing?
I started to
Jen or-
answer your question,
Jen or
but
Chris?
I just muted myself and gave you a whole bunch
Okay.
of information that was quiet. So I'll do it again. I think actually you covered the main things. Next steps, there's a summary note from today where you'll get a copy of that whiteboard. I believe that Denise and maybe Aaron might be bringing that forward to the accountable communities for health if interested, as a source point of things that people are looking for, intelligence and wisdom around what people are excited about and what people are longing for. Next steps about the next learning collaborative session. If you need the link, you can let us know. I can also put it in the chat before we leave. And the Mentimeter survey, any information that you give us there about what worked for you with this meeting, what you're looking for different, that's really helpful to know. We are still walking into one more learning collaborative meeting, so your input is welcomed and utilized. So please be candid. I have one more question on this poll that I'll go to so that we can see the results if they're popping up. And that's just one thing you're grateful for regarding the links between community and clinical care in our area. And I love this box here that says the people who do this work with me. I think that says a lot. So I'll leave this screen up, but Denise, I think you've hit all the high points and ready to close this meeting if people need to scoot. Is there anything else you need to say?
I don't think so. I just want to express gratitude and thanks for participating and for being part of this. And we'll see you at the May one on the 20th. And if anybody has any follow-up questions about the Accountable Community for Health, I'll try to get the slide decks out to everybody that were shared today. But if you have any questions about that work, please reach out to me or Erin Creeley over the next couple of weeks.
Sounds good. Okay, all, thank you very much. I will hang around for a bit, and if you need anything, you can let me know via the chat.
Jen, thank you as always. Oh, and thanks to the amazing committee of people that continue to meet and move the Learning Collaborative forward. It is a labor of love, and we are all very committed to offering this to our community. So thank you. And Jen, thanks for your support always and your continual herding.
Well, as you know, it takes a community, and that includes the planners, the interpreters, the participants, the facilitators, the technology. It all comes together. So that's what's wonderful about these kinds of events. Take care, everybody.
Bye, Jen. Thank you.